What does MIZ stand for in the last map? I think it stands for the metropolitan area, that is basically an urban center with more than 100,000 people in it. I think the thing that struck me about that map the most was just the extent of the green areas representing rural and northern communities. One of the things that we've done with rehabilitation is we've largely based it on models that suit an urban or a city context and environment. And then we've imported those models and tried to use them in rural and northern communities. And I would suggest that hasn't always worked, and we need to think about how we need to transform that delivery so that it really meets the strengths and particular needs that are very different in rural and northern communities than urban centres. Are children's rehab services included in basic healthcare funding for Indigenous communities? Unfortunately, not on the whole, no. Historically, they've been provided provincially. When I first started working 20 years ago, there were concerns about provincially funded rehab therapists going, for example, into unreserved communities. That is no longer a concern. They tend to be provided provincially, but we do now have this federal First Child Initiative, Jordan's Principle, and funding from that is being used to fund some rehab services. What is your experience of linking with allied health assistants in remote communities? Because this adds a cultural responsive care. The community that I worked in, we had a speech therapy assistant in the Lillooet Nation Band School. And she was supervised by a speech language pathologist who came into the community several times a week or a month, but she was there full time. And so she was able to do small group work with students. She was able to follow through on some individual approaches. So I think, we really need to start looking at and investing in, as they have in Australia, and to really invest in that approach. We are never going to have enough therapists to provide one-to-one rehabilitation, and neither do I think that we need to only focus on a one-to-one approach, but we really need to broaden the scope and really need to look at how can we support community members in this work through scaffolding their learning and training opportunities. So the other question that's coming up is, how do we make relationships with families, communities, when our therapists only visit communities 1 to 2 times a year? We have telehealth, but that only helps if there is already a relationship with the family. Yes, and I heard that from some of the therapists that I interviewed for the publication were from Northwest Territories, and they said a similar thing. And I think what we need to do is that funders and organizations need to understand that, particularly when you are new to a community, that you need to go into the community and focus on spending 2 days, 3 days, however many you can get, on building relationships. Put your agenda to the side. Figure out who in the community would be a good person for you to talk with, to learn about the community. Go to the school, go to the Head Start or the daycare program. This requires managerial support, and this requires organizations to really understand that cultural safety involves organizational change, that it isn't a matter of training rehab therapists to provide culturally safe care, that it needs to be supported by funders. And I think it needs to be recognized in how we provide accreditation to organizations, and also the statistics that I know many rehab therapists have to keep. So I think it's really just having that organizational support so that you don't feel pressured to see as many families, to do the assessments. Because unless you have a relationship in place, I would suggest that the work that you do will not lead to any effective or sustainable benefits or change. What has been the Indigenous families' response to Jordan's Principle initiative or support? Have these been evaluated? Are their needs being met? Well, that's a big, huge question that I'm not totally in a position to answer. But Jordan's Principle is enabling families to access some services that they wouldn't normally be able to access in a more timely manner, which would include rehabilitation services. Is that a sustainable approach? Is it a community-driven approach? I'm not so sure. So I'm involved with a research program based out of McGill, working with the First Nations Health Consortium in Alberta, and they are looking at evaluating the Jordan's Principle initiative in Alberta. One of the concerns that I have with the initiative is the division between them, and that I think all the initiatives across the country, we really need to come together and to learn what is working with that funding and going forward. Currently, the funding expires next March, and so we are waiting to see what will happen in terms of a sustainable approach. Another question is, how can we help the Indigenous population know that they have so much support available? I think the language that we use to communicate our services is key, but I would also keep going back to relationships. That I think when you're coming into a community or connecting with an organization for a time, that you need to be able to, and your organization needs to support you in this work, to be able to spend time actually saying and explaining, these are some of the ways that we could support you, but also tapping into what are some of the priorities in your community? What are some of the concerns? What would you like to see happen with the children in your daycare or your Head Start program? And then fitting in some of the approaches, whether it's interdisciplinary, whether it's a speech therapy, whether it's physio, and then thinking about initially how you could support those existing resources and services. But I would also stress that one of the things that I've done in the past is we become so immune to the language that we use that we forget that it's actually a medical language that other people don't necessarily understand. And we need to always be using really plain language in both our verbal and also our written communication. Here's an interesting question. Can you offer any comment on land-based models of intervention as opposed to traditional medical models? I think that's a really interesting question, and one that I think it's important for everybody to think about, because when you think about where we provide healthcare and rehab services for children, it's often maybe in indoor spaces. And how can we use outdoor, not just playgrounds, but how can we bring rehabilitation onto the land with knowledge keepers? For example, I've been doing some work with Head Start programs, and Head Start programs, some of them in the country, are looking at taking their programs outside and connecting children with the land, connecting children with the languages that goes with the land. And I'd love to see how we can tap into and build on that enormous strength in that area. But right now, I don't have any direct experience, and as far as I know, there's no literature currently around that. Yeah, I thought this question would come up. This is a question that I asked myself when I was working in community. And the question is it good that families accept their children as they are and see their strengths, yet they're entitled to support that they will not be able to access without testing applied? So this is I think that's a very complex question, and I think it also depends on the individual, as always, the individual family context and preferences. When I first started working in community, I routinely did assessments. 10 years later, I was barely doing assessments because they weren't proving useful to me or to the families or the children. When I would do an assessment, if it was to access a piece of equipment or a specific resource, and then I would have a conversation with the parent and explain to them that we're going to do this assessment, and we're going to do this assessment and write it up in a certain way in order to be able to access this particular resource, program, funding that could benefit your child. And we would only do that, obviously, if the parents were in agreement, but it would be a very transparent process. I think one of the things we need to think about here is that relational context and the nuances of families' concerns about having their children assessed and tested, and concerns about heightened awareness from the child welfare system, and if that's playing into concern. But I think there also are possibly parents who really do feel that they want to wait until their child gets a little bit older and that they want to focus on what their child is able to do and the gifts that their child has, rather than focusing on what the child cannot do. In order to be responsive to that approach, I then think we have to question the current provision of services in Canada for rehab services, which involve decreasing services as children enter the school system. When we think about children's rehabilitation or early intervention therapy, it often goes from birth to school entry. And then in many jurisdictions across Canada, as soon as children enter school, the availability of those services go down. In BC, we're currently looking at extending that period into the primary years. I'd love to hear from others in the audience if you're doing that. I'd love to hear from you on how that's working. But I think we really need to look at that as well in relation to being able to address children's needs in those primary years if we haven't got them before they've entered school. So there's a comment and a question here. I would respectfully suggest that your definition of cultural unsafe service is really talking about the lack of human honor and dignity that occur with any individual, personal unsafety, if you will. And cultural safety would be perhaps broader than that. I completely agree that we need to work on valuing and evaluating the human connection with every encounter. However, I think that this can be an intervention that may arise out of the search for cultural safety, but it is only valuable when implemented broadly for every individual. I don't know how to evaluate this. Do you have any ideas? Yeah, the definition that I used of cultural risk, I think sometimes, cultural safety is sometimes a difficult concept to get your head around because people get caught up in the notions of culture. And it really is a very broad concept that broadens the scope of health beyond individual experiences to looking at the influence of broader social factors and colonization. That definition of cultural risk, I think, is a really nice, tangible way of reminding us that there is a lot of research showing that Indigenous peoples in Canada avoid accessing healthcare because of risks, wanting to not face dismissal, discrimination, and racism. The only way that you can evaluate if your service is culturally safe is to engage with the people that are receiving your service. So for organizations that are not Indigenous, it would involve asking, how are Indigenous peoples represented in the way that your organization is delivered? Do you have Indigenous representation on your board? Do you have a safe, anonymous way for families to give feedback on their experiences? And so I really think you have to look at how you are accessing those experiences from families as a way of understanding, are you providing care, those experiences as culturally safe? I hope that helps. The other question, are there any rehab schools in Canada or elsewhere in the world that incorporate or require clinical placements in rural, remote areas, as is often done in medical training? I don't know. I'd be interested to hear. And we do have here at UNBC, there is a physiotherapy program connected with UBC for physiotherapists, focusing on placements in rural and northern communities. So we have that here for physios. I don't know anything about occupational therapists or speech language therapists. But what goes with that question, though, is also thinking about, obviously, the curricula. And again, the concerns around importing urban-based programming and models of delivery into rural or northern contexts. And we really need to think about how we can tailor our programs and do things differently, and also maybe how we need to fund them differently in order to address the enormous travel and time involved in those communities. So there's a question about assessment. What would you recommend for developmental screening tools, infants and toddlers, i.e. the ASQ, which is the Ages and Stages questionnaire, that is respectful of culture and communities? I think there's two parts to your question here. There's the tool, and then there's the relational process. So in terms of the ASQ, is being used in many Indigenous communities and programs across Canada. And there is some research where they've looked at the relevancy and use of the ASQ with a Mohawk community in northern Quebec, I believe. And so that research is available, and I'm happy if you want to email me to send that to you. So the ASQ can be used, as any assessment I think can be, in a strengths-based way. As far as I know, there are no standardized tools that have as their sample population a real meaningful representation of Indigenous children. So in terms of validity, that's still a concern. But I think there's also a real concern about how you use any tool with a family. And has that relationship been established? Have you given time? Why are you doing that assessment? If it's for your own clinical reasoning, I would really find that questionable. How is that assessment going to benefit that child? How is it going to benefit the family? And how can you do it in a way that really gives control and power to a parent or a caregiver that you're doing it with and is useful for them? So I think they have to be used extremely cautiously and carefully. But I'm also aware that you're expected to use those by your managers, by your funders. And again, that's where I think cultural safety, people need to realize that there has to be an enormous shift in our funding and organizational expectations. How, if at all, have you experienced provincial differences in the prominence of available support to Indigenous families across Canada? Well, I actually have had a recent experience of that. When I started off providing occupational therapy with the Lillooet Nation, and I also provided occupational therapy with a preschool in the Squamish Nation in North Vancouver, which is an urban area. And the Lillooet Nation is a rural area, but it was within commuting distance for me when I was living on the North Shore in Vancouver. So I had that experience, and then as an occupational therapist. And then recently, I've been doing some research in northern BC, where I've been listening to stories from Indigenous parents, families, and early years professionals about their experiences of early intervention children's rehabilitation. We call it early intervention therapy here in BC, in the north. And I'm quite shocked at the difference. I think there are lots of issues about providing equitable access. There's physical access issues in that it's hard to recruit and retain therapists here in rural and northern communities. I think they often tend to be based still in urban centers and travel out by car or flying in, flying out to rural or northern communities. And that brings its own challenges and priorities. So there's those access issues, but there's also, again, the cultural safety issues around those relationships. And so the amount of time it takes to travel community, I think, can put enormous pressure on therapists to think, okay, it's taken me a day or it's taken me half a day to get here, and I'm here for only 2 days. I'm going to have to assess all the kids, and I'm going to have to write reports and then send them back. And I would say only when you've got relationships in place in the community. So I hope there's some managers and funders on the webinar who are really hearing this message, that we need to give permission for therapists to do this important work. And yes, it takes time, but it is more important than any assessment and any report. And any report that's written without a relationship in place is going to, I would say, have a limited value and benefit. Many rehab referrals are initiated from a tertiary centre or clinic. So, for example, here in BC, it would be BC Children's Hospital. How can urban tertiary service rehab professions best partner with local communities? At the BC Children's Hospital in Vancouver, and there is an initiative underway there to try and improve the continuity of care. Yeah, I mean, I think it depends on what rehab services are available in the local communities for a start, and are they there? I think there does need to be more thought put into that continuity of care that goes beyond sending a report back, that there needs to be involving the families to have some really safe sort of relational spaces where, and maybe using technology, where a central hospital like Children's Hospital and a local community and the family could come together and talk about how the child's needs could best be met. And it may not be best met through a rehab service if one's available at night. But again, it's another area that we need to really think about for all families who are living in rural areas, including Indigenous families. As an OT, do you have any culturally safe tools that you use to help families identify priorities for services? Have you used the Kawa model with this population? I haven't, but I think there is some research of using that model in New Zealand, and I could definitely find that for you if you wanted to connect with me. I would say the most culturally safe tool to help families identify priorities is spending time with that family and listening to their concerns and learning about their story. Because only when you understand a family are you then able to understand where you might fit in, what you might be able to bring to that family. And I think you need to do that through a relational process. The Kawa model might be helpful, but again, bringing out a model or bringing out papers, bringing out anything that looks more formalized can be a problem because it can create a barrier, it can create concerns and fears, and it can take away from the fact that you need to listen to a family. I'll just share a story that I had, again, back when I was working with the Lillooet Nation. I worked in the community for a couple of years as their occupational therapist. And initially, the nation funded me, so I had a lot of institutional freedom. And they said, will you see children and youth that have special needs? And I said, yes, of course. And then they said, well, we have some adults and elders, and you're the only occupational therapist, so will you see them? And of course, I said yes. And so when you're working in rural communities, you may need to have that broader generic focus. You may not be able to focus on just children and youth. So that was one point I wanted to make. The other point was that I worked in the community for 3 years, and then I was doing my master's, and I got permission from Chief and Council to do a very small qualitative study with members of the Lillooet Nation who were families who were raising children with special needs. And I wanted to understand about their experiences of raising their children and of working with people like myself. So the participants in the study were also clients. And the thing that I still remember, and this was over 16 years ago now, was that I was interviewing a mum who I'd known for several years. And as a qualitative research interview, I asked a very open, very broad question, something like, can you tell me about, and it was her daughter, who was my client. And in asking that question, she told me things that I hadn't learned for 3 years being her occupational therapist. Because I think I always had that lens, I always had that agenda, and I never gave myself that space to say, tell me about, over time, you don't want to make it really pressure, but tell me about your family, tell me about your children. The other thing that happened in that interview, and some of you, if you've heard me present before, you tell this story because it was a very powerful learning experience for me and for learning about my positionality and where I stand, was that mum said to me, do you remember the day when you came for a home visit? And in the community, I would rarely do home visits. Families felt much safer meeting with me in the daycare, preschool, in the school setting, in the clinic, and I very rarely went to home visits. And I said, yeah, I remember we came and we did something in the home visit. And for me, it was a routine visit. It was not anything out of the ordinary. And the mom said, that day I was really frightened and I was really scared that you would judge my house to be not up to your standards and you would take my children away. And that was the first time that it really hit me full on, whether I like it or not, the power that I represent when I come into community and the power that you will represent coming into community. And I've heard even from Indigenous early years professionals, for example, who are working in their own community, also face similar challenges. But for me, that was a really important learning experience that I still hold with me. So another question, what theoretical frameworks did you consider with your research? You indicated you work from a relational paradigm. Did you have to lean into some critical theory? And do you think that it's important to shape your practice? So anybody that knows my work, and if you look at some of the resources, here's a story. So what happened when I did my master's research is I didn't know anything about cultural safety. This was back in 2002. I used a very culturalist perspective, thinking about cultural sensitivity. I was very uncritical. Then I got into learning about cultural safety. And cultural safety from a critical perspective, for those of you who are into critical theorizing on the call, it's been framed as a tool of post-colonial theorizing, a critical theory, because it draws attention to the historical and the ongoing impact of colonial structures and policies and discourses on Indigenous people's health and well-being and everyday life. So yes, during my doctoral work and my postdoc work, I draw on post-colonial and feminist theories. I also draw on Indigenous feminist theories. And more recently, during that work, I've started to look at relationality, which is aligned with many, not all, but with many Indigenous worldviews. And a paper just came out this week where I talk about how I think relational knowledges can help us do research in a good way that doesn't perpetuate a colonial style of research. Given the prioritization of a relationship approach to wellness in Indigenous populations, have you found opportunities to collaborate with other service providers, health, education, social services, community programs? Yeah, thanks for that question. So here's the thing. Two things out of that question. Focus on wellness. I know as an occupational therapist, I'm aware of their scholarships, and I am physio and speech therapy. But at the World Federation of Occupational Therapy conference recently, that was 2 weeks ago in South Africa, one of the keynote speakers was Karen Wally-Hamill, who's a Canadian critical theorist, and many of you may know her work. Her keynote speech was about the need to shift from disability to wellness. And there's also critical scholarship in Canada that really is trying to make this shift, to really focus on what families, communities, children are able to do, what are the strengths they're bringing. That involves shifting what we're teaching students at universities and not focusing on maybe so many deficit-oriented models or biomedical models. And it also involves, again, shifting organizational expectations. The other thing with this question that brings up for me that I haven't touched on is to understand the absolute importance. If you're going to want to provide services that are socially responsive or culturally safe, you have to have extensive community relationships that cross boundaries that maybe you don't typically cross. So you may have relationships with Indigenous early years programs, with Head Start programs, with the local food bank, with housing initiatives. So in order to provide care that really attends to that broader perspective of health, you have to broaden the scope of the relationship and broaden the scope of what you're doing. And again, that will take time away from more individualistic approaching. Would it be more beneficial to have actual Indigenous healthcare providers? Yes, it would. And so, as we move to, in Canada, a master's entry program for rehab professions, it's tough for people to get into the profession. And I have to say that I don't think I would get into the profession if I was trying now to get in. Because I don't have the qualifications that you would need necessarily as an entry when I was back trying to get into OT. So I think we have to really think about, yes, and what's happening in Canada, which is hopeful, is that we do have Karina and another Métis, Karina and Angie Phoenix, are occupational therapists who self-identify as having Métis ancestry. We're all presenting together at the OT conference in a couple of weeks. And Karina and Angie chair a national network of occupational therapists that are working with Indigenous communities and families as a network. What's happened through that network is that more OTs are self-identifying as having Indigenous ancestry. And that's not always a safe thing to do. So that's happening. In the SLP literature, so most of the literature for that publication, most of the research that's being done in Canada around this is being done by speech language pathologists. So if we have OTs and physios on the webinar, I would say we need to step that up. There are a few, again, SLPs that self-identify, and a few physios as having Indigenous ancestry. The other thing that's happening, though, and I know Karina has talked about this as well, and Angie, is that you need to have safe spaces within our educational institutions, not only to self-identify, but you also need to have other worldviews that represent other ways of thinking about health and well-being and health care besides a Western biomedical approaches. So there's never a quick answer, is there? So we've got 10 minutes left. So this question is, how do you recommend we speak to parents about the areas we think would be valuable to work on with their child if we are trying to reduce our use of words like delay, disorder, disability? Do we still make it clear that their child has areas of difficulty? So I think I would answer that question by saying, pull back a second and think about the child that you're asking that question about in relation to their family and their community. And not until you know the community and you know the social context of the family do you then want to have any kind of conversation about an individual child. And your use of wording would really depend on the trust and the relationship and how well that is established. And if the relationship is fairly tentative and new, then I would really focus on hearing what the parent is interested in learning about their child. What are their concerns? What are some of the things that they can share with you without using any of those terms? I really think we need to avoid those terms, actually, completely if we can. And think about, well, maybe we'll look at play. Maybe we'll look at going outside on the land, and maybe we'll look at using that space. So we have to frame everything around this whole disability context. I know it's a challenge. It's how we're educated. It's how we're expected to provide rehabilitation. The thing I love about the work that I've done and the learnings that I've been privileged to have within Indigenous communities is that it's really pushed me ahead to really challenge and think about my assumptions. And it's not the kind of work that's for everybody, but if you're happy with being uncomfortable, then I think you really have to sort of start. And it's a great question to ask yourself and to keep in mind when you're next meeting with family. So this question is, what tools or mechanisms do you think would communicate out the permission to do the relational work required, assuming funding wasn't an issue? Well, great that funding isn't an issue. Yeah, I think this is going to be a shift, right? This is a shift in a way of thinking, in a way of doing, in a way of relating with people. And it's also a shift, like I kept on mentioning, power, right? It's a shift in power to say, if you want services in your community, how do you want those services to look? Who do we need to connect with? Who do we need to talk with? How can we learn about? What are the priorities? And so that's your starting point. The work that I did for my doctoral research with the Aboriginal Infant Development Program, which is an Indigenous early years program here in British Columbia. And what the consultants in that program told me is that when they were starting a new program in a community, and they had the luxury of doing this, I'm not saying you have to do it this long, but they would sometimes spend weeks in a community just getting to know the community and building those relationships before they even thought about what their programs or their services might need to look like. And so there is no one relational approach. There's no one relational framework. It's more an overarching, I would say, philosophy that guides this community-driven approach. But on saying that, there are certain things that are aligned with the relational approach. And those are cultural safety, trauma and violence-informed care, and harm reduction. And I would encourage children's rehab therapists, if you're not familiar with harm reduction and trauma-informed care or trauma and violence-informed care, then those are equally as important as cultural safety. And they all share this relational approach to thinking about services. What do we know about issues of cultural safety for Indigenous children and families who are living in large urban centres? Do they feel excluded or marginalised in these settings? Is there literature in this area? Yeah, great question. Yes. So when I talk about Indigenous communities, I'm very cognizant of families that are living in urban centres. One of the, I think, exciting things that's happening in urban centres are the enormous strengths and resources that are friendship centres. So if you are working with Indigenous families in urban centre, and if you have not connected with a friendship centre and you have one in your centre, then go there right now and introduce yourself. So friendship centres provide a really diverse but broad range of services that support family, community well-being in the broadest sense in an urban context. They often provide early years programming. Sometimes they host Head Start programs. One here in Prince George, where we are today, for example, the Friendship Centre has funding to provide its own speech-language therapist, and they're applying for funding for their own occupational therapist. So I think those are hopeful avenues that those services need to be connected with, if not hosted by, local urban Indigenous organizations. I think that's happening too in Winnipeg. I know we've got lots of folks on the webinar from there. And I don't know if there's been any research around urban Indigenous families' experiences of rehab, Gail, as far as I know. There's been some literature around Indigenous people's health, and there are some publications on the NCCAH website that speak to that, but not specifically to rehab services. So one more question. Okay, great. How does the term rehabilitation resonate with Indigenous people and their communities? So rehabilitation is not a word that I use in my work as an occupational therapist or as a research partner. And the reason I used it for this webinar and this publication that's attached to the webinar is because of the literature that I was drawing on, that the literature I'm drawing on both nationally and internationally is framed around this idea of rehabilitation that comes with certain underlying sort of principles and assumptions. I don't use that word. I actually think probably it will get misconstrued as having something to do with maybe rehabilitation for maybe other health concerns and issues. So yeah, I don't use it. And actually here in British Columbia, our programs are called early intervention therapy. Again, the word therapy can be misconstrued as well. I think language is really important, and I don't have always the right language. So thank you, everybody, for not only attending, but asking so many wonderful questions. You have my email, and please connect with me, and thank you for staying the course for the whole 1.5 hours. And I look forward, hopefully, to meeting some of you in the future. Thank you. Bye-bye.